Welcome to All Things Chiropractic.
Welcome to another episode of All Things Chiropractic. I'm Paul Andrews.
I'm Dr. Mark Davini. Welcome all.
Okay, we've got a topic today that I think is going to resonate with everybody.
Well, maybe everybody but me, but go ahead.
Right. So, docs out there, have you ever had a patient who just doesn't seem to get better? Someone that just, not that they're not responding to your care, but they're just not resolving. They're just not getting clinically to a goal that you expected or anticipated that they might get to.
You know, it's a great question too, because interestingly, the old statistic used to be that, chiropractic is the 80, 10, and 10. 80% got better, 10% improved, and 10% didn't respond. The difference is the 10% that might not have responded to my technique might respond to your technique. So we didn't always have the same 10% of non-responders. So this person could go somewhere else and, all of a sudden, I'm this way and they go to another doctor who practices a completely different discipline and they respond. So
You mean like every chiropractor under the sun? Because nobody
Yeah.
does the same thing.
nobody does the same thing. Exactly.
Yeah.
And that's exactly the point, right? That don't take it that you don't get patients better. Take it that your particular approach to chiropractic may not be what that particular person needs. So let's qualify that right up front. Chiropractic works for everybody. In one way or another, everybody needs to be adjusted.
But let me ask you a question, because you're the clinician in the room, right? I'm just a lowly lay person. How and when should you know as a clinician when the non-response is happening?
Well, and again, another great question, because you look at this and you go, you only ask great questions, right, Paul?
Hey, listen,
Yeah, I was waiting.
who am I to argue with the expert?
But I mean, think about this, that a patient may come in with, for example, low back pain, and they may have
Do they go to chiropractors for that?
just a few,
Yeah.
just a few here and there, that rarity. But they come in and they might have a physical condition that is so bad that they might not improve for low, they might not be able to improve their low back pain. Now, that doesn't mean they don't need to be adjusted. That means that your particular set of tools or that patient's particular condition is not going to improve by what they're looking for or maybe even by your standards. But again, it doesn't mean that they don't need to be adjusted. It just means that adjustments are not going to help their low back pain.
Okay.
So you have to set up that difference between that vitalistic mindset and that mechanistic mindset.
But let's break it down, because you're really talking. There's a couple different things we're talking about. One is the patient's expectations of clinical improvement need to be understood and maybe tempered based on their
Exactly.
actual condition. But then there's also the doctor who may have assimilated all this data and said, well, I know they're going to respond this way and they're going to get better in this time period. And then the patient doesn't.
Right. Right.
Right.
And this is what I mean by clearly defining your goals, their goals, what it is chiropractic may do or may not do. And again, when somebody comes in with a particular situation, your job is to evaluate that situation and determine whether or not chiropractic will help them for the reasons why they came to the office. You may be looking at them saying, yeah, but I can reposition you to be a lifetime patient and you'll gain the benefits of chiropractic forever. Don't get me wrong, believe in all that. But they have a reason for being there. And your responsibility is to address that reason. That means a good history, a good exam, you diagnose them properly, you treat them properly, and you manage them properly for that condition. And then you either resolve it, like you said, maybe you don't resolve it. But one way or another, this patient has to understand that chiropractic has a vitalistic component to it beyond the mechanistic component of just getting a symptom better. So, and the problem becomes when all this gets mixed up, like you said, it's all over the place. And chiropractors aren't even clear what they're doing. They look at that patient with the low back pain, they come in, and their mind is thinking, oh, how am I going to get this person to come back and be a patient forever? Well, you got to get them well first by their definitions of well, not your
Yeah,
definitions of well.
okay. But if we were to sort of like dive in a little bit deeper, right? I'm talking about patients looking for a particular goal. Typically, it's to resolve symptoms, right? I mean, that's
Right.
most of why people come to chiropractors, at least in the beginning. It's neck pain, low back pain, whatever. But they're not getting better, right?
Right.
And the doctor is maybe saying, "Well, let me mix things, let me change things up a little bit, and I know you'll get better." But how long does that go before you as a clinician say, "Well, they're not getting better, so something isn't routine, something isn't typical.
Yeah,
This is
well,
not."
there is an algorithm for clinical care and management,
Oh, what
and
insurance
the
carrier
ge
are you gonna quote here? Just kidding.
not insurance, no, this is us. This is the real clinical world, okay? And the general rule of thumb is that, a patient should improve significantly within the first 2 weeks of care. Now, they're not gonna be better, but there should be some measurable improvement in why they're there, the symptom, like you're talking about, right? If they don't respond in the first 2 weeks, then you can change the approach and give it another 2 weeks. And again, they don't have to be all better, but there has to be some indication they're improving significantly in a meaningful way. If at the end of those 4 weeks, they haven't demonstrated any improvement in any meaningful way, then for the most part, you should be referring out to either exclusively get out, no longer, I can't help you, goodbye, or referring out as an attempt to co-treat. So maybe they need something else. So there is a criteria out there that is basically generally accepted, and you know, Jim Cox had been treating this teaching that for 1,000,000 years, and the rest of the people have caught up with it, and it makes sense. It makes sense if you're going to be focused on that symptom, that there is an expectation that a patient should improve, say somewhere between 2 and 4 weeks. And if all of a sudden they're not any better, then you've got to do something outside of just chiropractic at that point.
Are there objective, um, exams that can identify a patient who is either exaggerating or malingering or
Oh yeah,
lying?
there's orthopedic tests that they call them malingering tests. There are malingering tests that you can do for certain conditions depending upon the situation. And
Not that a patient would ever lie to you.
no, here was one of my malingering tests that I think I told this during our X-ray segment that men I used to have men drop their pants to take the
Excuse
low
me?
back pants, to take the low back X-ray.
I think I found our snippet for social media.
Yeah, they were yep, the snake. Yep.
There it is.
Yeah, they were given a gown top if they wanted
Uh-huh.
it, but then, up until the point where the X-rays were taken, they'd have to drop their pants and they could have their underwear on, right? Well, it was interesting how many men could claim they couldn't bend over
Oh, yeah.
and when you were doing the exam, but when it came time to pick their pants up, they shot right down
Yeah.
and picked them up.
That reminds me of a funny little story. I was
Mm.
working as the CA front desk, and this kinda wackadoo patient, she came in on a motor vehicle accident. She's one of those patients that you love her, but she wouldn't stop talking, and loudly, like, she'd have a conversation with the room, and nobody's listening, right? And she's talking with both arms, and she's up and down, and her arms are going up, and they're going down, and they're all over the place, flailing.
Must be Italian.
As soon as the door opened, the doctor called her name. She holds her left arm like she can't even move it. Walks in the room. I had to tell the doctor after, I'm like,
Oh.
"You realize, like."
Well, when we used to sit around and have dinner, everybody had to have at least 3 feet apart from each other.
I mean,
Or
but I
we'd hit
mean,
each other and knock each other out. Yeah,
she's there
yeah.
because of a frozen shoulder or something, so to speak, from a motor vehicle accident,
Right.
and there she is having a
Mm.
conversation full blown, full range of motion on both arms.
Uh,
And I'm just like, "Oh, okay.
yeah,
Okay.
well, there are orthopedic tests to kinda do that. So even though I started putting my men in shorts, um, but
That's better."
that's better, but it eliminated one of my best tests, so I had to incorporate malingering tests, but they're out there. Yeah, you do have them out there. And most of the time, when you're doing your exam, like you said exactly, there's inconsistencies. "Ah, I can't move, I can't move, I can't move," and then you have them do something else and they're moving. Yeah.
When do you think, or maybe this happens, it doesn't happen. When do you think a chiropractor or any provider, it doesn't even have to be a chiropractor, any doctor, that their ego starts to get damaged because they're expecting and the patient almost becomes something that they're challenged by, that they're going to make this patient get better. They're going to,
Mhm.
and
Well,
they're not.
nobody wants to think they failed, and the word "failed" is the wrong one because we don't fail. They call it practice for a reason, and when you think about it, somebody is just not going to get well according to your expectations. It's just that simple. If we could heal everybody, no one would die. So we
Yeah.
have as a reality in life, we age and we die, and that means that somewhere along the line what healthcare is doing as an intent isn't working because our intent is to make you well and make you live a long time forever and always. So we do have failure. It's called death. So
Yeah.
ultimately, you have to accept it in the healthcare world. We can't fix everything for everybody. That's why the 80-20
Yeah.
rule.
I was at a massage conference not too recently, and I just remember this one therapist was talking to a vendor that was there that had just been in a car accident. And this massage therapist just kept hammering her, saying, "I can get you better. I can assess you. I can fix you. I can do this. I can do that."
Oh,
And I'm
jeez.
listening to this and I'm just saying to myself, I don't think this is about the person you're talking about. You're really talking, everything's about you as the practitioner, not
Mhm.
the client or the patient in front of you. That vendor was picking up what I was thinking anyway, but I was saying to myself, like, this could be this is unfortunate, but it also could be damaging, right?
Oh, for sure.
Even as a massage therapist, you're working on soft tissue, and if it's not relenting, I'm gonna make it relent. Like, okay. Like, I know
You wanna
Graston's a
gauge to see if
technique
you're the
and yeah.
yeah, if you're really doing a great job. Do you know what the ultimate gauge is? They come in, they have a problem like low back pain. You teach them about what you can do or may not do for their low back pain. You make them understand chiropractic. They don't respond in the low back pain world. You refer them out for some other procedure with another practitioner, and they still come back to you to get adjusted. That's when you
Well,
know you've really, really succeeded because you've made them understand that your symptom may or may not respond to chiropractic, which has nothing to do with whether or not you should be adjusted on a regular basis.
well,
Now
if
that's
you and if
not
you're under
that's
30,
not
it's five-star reviews and,
right,
social media
right. Well,
acknowledgement.
I'm just saying that doesn't happen as often as we want it to, but, if you're going to set a high standard or a high bar for yourself, let it be that I know I can't get every symptom well, but I know everybody needs to be adjusted.
What's your opinion on, lots of chiropractors are, rightly so, attached to their particular method.
Yeah.
And to say, well, we've ruled out comorbidities. Maybe they just need a different chiropractor. Like, does that actually happen?
Probably nowhere near as much as it should in chiropractic. Certainly happens in medicine all the time, right? I mean, all the
Well,
time
because
in
they all
medicine.
specialize in like the most.
Right. And most of the time they have no problems having a limited reservoir of information and procedures. But yet, since we're always chief cook and bottle washer, we're the mavericks, we're the ones that are out there all by ourselves. We've spent all this time going to school and, I can get you well. And I think you have to spend the time to do what I said earlier about incorporating some version of that algorithm into your practice. So when you know enough is enough, because there will be those patients that just won't or can't respond to either chiropractic or at least your version of chiropractic. If you refer them to someone else and they don't get better, you can at least say, well, this person really isn't someone that was going to have their symptoms relieved by chiropractic.
Well,
Think
you
about
know,
the patients, don't think about you. Just what
it
you said.
and it makes me think about, Dr. Bill Owens. Like, we had him on our podcast. He built a career and a whole plan and program on co-managing, right?
Mhm.
And there's no to me, it's like, if you are having if you're needing to refer out because there's either clinical signs, symptoms, or issues that are beyond your scope, it doesn't mean you have to let that patient go completely unless it's
No,
contraindicated, right? It's more of a
exactly.
co-management situation and a learning opportunity for both you and that
Yeah.
other
That's
provider or
putting your
providers.
adult pants on or
Eh,
whatever,
not
you
your
know?
adult diapers, doc.
No. Phew. Recognizing recognizing that you don't know everything, and if you really do think you know everything about everybody, you don't even know what you don't know.
Do
That's
you
how badly
Hey,
you
doc,
don't know.
do you know what you don't know? Just kidding.
I know that the more I learn, the less I know.
Boy, is that true about everything
Yeah.
and everyone, you know?
Yeah. Yeah. So
Yeah.
if you really do think you're supposed to have all the answers for everybody, I feel bad for you because that's not the real world at all. And that's going to make for a very frustrating practice, too, by the way.
So who do you think falls victim to this more? The new doc, the sort of like sophomore doc, or the seasoned doc?
I'm going to go with the seasoned doc
Yeah.
because we had a stronger philosophical orientation. So, philosophy in a sense, is more of a belief system. There's no fact to philosophy. It's a belief system. You orient your thinking in a certain way based upon your education and experience and generally your belief system. So we were taught way more, much more philosophy than students are being taught today. The words evidence based never entered our vocabulary. Okay.
I still have a
Now,
problem with that because unless
yeah,
they're pouring money into research, which they're not
no.
in many specialties, including chiropractic, the only evidence based is every single practice in the country is a microcosm of research.
Well, what's evidence too? And we've talked about that a little bit, but everything is evidence. Observation is evidence. So you have to define the level of evidence that needs to be in place to qualify it as an evidence-based procedure or program. But I think the younger docs have that orientation more than we had it when I was going through school. We had, you know, this is what you do, this is why you do it, this is how you do it, and then you have the belief that the power that made the body can heal the body. And that we backed up to that a lot.
Yeah.
We backed up to
Well,
that a lot, especially early years of practice. We
yeah.
we we fell back on that a lot. Where now I think they try and second guess everything a little bit more. Um, and that's I don't say it's good or bad or indifferent. I don't say one's better than the other. You just asked the question, and I just said no. Older, definitely.
I didn't say older. I said seasoned, by the
No, I'm
way.
answering. Older.
FYI.
Yeah, seasoned. Many seasons. Yeah, yeah.
So
It was
what's your
different.
best
It was definitely different.
takeaway advice for doctors when they have, patients that aren't responding like you expected, and, you're not sure why, Is it them? Is it the patient? Is it both?
Well, if you really think it's that chiropractic is their answer, and you think it's just not responding to your technique, send them to another chiropractor. That's number one. If you do believe that there might be some type of underlying medical condition that will not respond to chiropractic, then refer them out for another opinion. And like you said, referring out doesn't necessarily mean out of your office. You might say, look, I need you to see this neurologist. Based on what the neurologist tells me, we can decide whether or not we just need to put more time and effort into this or it's time to pull the plug. And they respect that. Patients love that. They actually love being co-treated. Just their idea is that everybody's paying attention. Everybody's caring for me. So referring out doesn't mean necessarily get them out of your office. Maybe they just need an MRI. So let's order an MRI to make sure what I'm doing is what I should be doing. And it's just you're one of those that fall in the 10% that's going to take a little bit more time. That's all.
Hmm. And then you order the MRI, and then it's 3 weeks of paperwork trying to get it authorized. But yeah,
Yeah,
exactly.
by that point, they're better.
Yeah,
I,
exactly.
I used to always say when we knew there was an insurance company that had that much work, and they came in as a new patient, I said, "So let's start the process for ordering an MRI, and by the time it's approved, we'll know whether or not this is working."
And like there was a recent patient in an office paid out of pocket for the MRI. The MRI found something. And I said to myself, if the MRI actually found something, that carrier should be paying that.
Mhm.
If you want to, if
Absolutely.
you want to basically gamble as a patient and put the money up front, I think it's BS that if there was a finding that the insurance company would then say, okay, my bad, I should have paid for it. But
Yeah,
no, the patient's still stuck with it, which is
yeah.
ridiculous.
Well, they don't have an appeal for that, do they? Is there an appeal process for that? You know?
Yeah, there's always an appeal process, but I
Yeah.
mean,
No,
who's
you
going to
should
waste
have
their time with
paid. I
that?
want my money back. You should have paid.
Yeah,
That'd
right.
be interesting. I'd
Well,
love to
they
see
don't
that.
call
Have
it
that
post
patient do it.
authorization, they call it prior authorization. So,
Yeah. Yeah. How
but
about
don't get me started on that.
post-authorization? Yeah.
Don't get me started on that.
Don't get me that's a whole other podcast we did,
Yeah,
right?
boy,
Yeah.
exactly.
Yeah. So,
All
I
right.
mean, it is just setting realities and setting expectations that are real and having a set mind algorithm in your mind. Like, you know what you can do, especially the more you do it and the longer you do it, you know how patients are supposed to respond to what you do. And if they're falling way outside that parameter, please, doc, don't just keep pounding away on these people. You know,
Mm.
I'm not saying you don't have to treat them, but I'm saying you might have to bring something else in.
Yeah, I don't think I mean, to me, it's like, hey, you bring in other specialties. And a lot of these specialties in the medical world are so used to co-treating, like it's nothing
Right.
to them.
And like Dr. Owens was saying, if you don't have relationships with a neurologist, an orthopedic surgeon, their primary care, these are the people, rheumatologists, these are the people that you need, physiatrists. First of all, half those people I just rattled off work on a referral basis. So they love getting your patients. They really do. You have to make them understand that's, you're not dumping your worst cases on them. You want to maybe co-treat with them if possible. But it's interesting. I was just looking at a file and I recognized the name of an orthopedic surgeon that I remembered from way back. This guy's got to be about 100 years old and he's still out there
I'd
doing.
agree with that.
Yeah, no, he was older than me.
Yeah, I'd agree with that.
Way older than me.
Uh,
So I was surprised when I saw his name and I said, "Oh my god, is he number 1 still alive
yeah.
and number 2 still performing surgery?" And he did. And this
Mm.
guy would refer people to me. I won't say regularly, but I will say commonly. If they wanted a chiropractor, he sent them to me. And this is a guy that didn't like chiropractors.
Well, look at you, Mr. Special. Excuse us for
Oh, it's
living,
just
huh?
it was just one of those things where he said, "Well, if you're gonna go to one,
Yeah. Yeah.
go to this
Right.
one. I don't
If you're gonna
believe
make the
it."
big mistake of going to a
Yeah,
chiropractor, at least go to this
yeah.
guy, right?
If you're gonna screw yourself up, go to this one, at least he won't
Yeah.
screw you up too badly.
Yeah. Yeah. Exactly. Oh my
That was
gosh.
pretty much his attitude, but
Yeah.
so the relationships that Dr. Owens was talking about is perfect,
Yeah.
if it answers this question that we're talking about today.
Yeah. Well, good stuff.
Good stuff. That good stuff. So, just get out there, do what you do, know what you're doing, be aware. Present time consciousness. We always bring it back to
Mhm.
that, right, Paul? because
Well,
hope is not a
Parker had it
treatment
right.
plan.
So,
Right.
yeah. Boy, did he
Yeah,
ever.
hope is not a treatment plan. You get that.
Yeah, exactly. Yeah, well, thank you again for listening to another episode of All Things Chiropractic. I'm Paul Andrews.
I'm Dr. Davini. Thank you all.
Thanks for listening to All Things Chiropractic. We'd love to hear from you. Visit allthingschiropractic.com with comments, episode ideas, or questions. Or connect with us on Facebook and Instagram at All Things Chiropractic Podcast. Be sure to join Dr. Mark Davini and Paul Andrews next time for another episode of All Things Chiropractic.